Thank you, Nicole. Hello, everyone. My name is Camila, and my fellow health associates are Manal and Kishan. Over the summer, we've had the privilege to work with CerebroSonics. They've taught us how this project can make it into the market and change lives. Strokes are the second leading cause of disability around the world. However, CerebroSonic will minimize time diagnosis and expedite treatment. We've gotten closer to this dream thanks to the mentorship of Travis Lord, Kristen Backer, Elisa Maldonado, and Ben Fauber. As health associates, we foster collaboration between team and mentors. We assisted them in the preparation of their pitch, and we research avenues for future funding. However, this wasn't only a mentorship experience for CerebroSonic, it was a mentorship experience for us. Thank you to CerebroSonic for the advice that they've passed us about life and about career as undergraduate students. And now, I would like to introduce Bharat Mathur, the medical robotist behind this project.
Hello. I'm sure we all know someone who's had a stroke. With 15 million cases in the world every year, they're very common. They leave 6 million people dead, another 6 million disabled for the rest of their lives. Why are they so bad? Well, even though we have very advanced stroke treatments, they're only good if delivered on time. There are three types of strokes, each requiring different treatments, available at very different hospitals. So taking the patient to the right one is incredibly important. The limitations of current diagnostic tools cause treatment delays across the continuum of care, from EMS, the first point of contact, to EDs, and finally, while the patient's recovering in the ICU. There's no way to continuously monitor the progression or complications that may occur in about 50% of all patients. Our solution is a portable brain imaging system, which is wearable, delivers bedside readable, real-time scans, and is non-ionizing, allowing for repeat, short-interval ICU monitoring. We give the three things required to make any treatment decision for any kind of medical pathology, which is the what, which is differentiating stroke types, the where, localization in 3D space, and the severity, which is the how big, which is volumetric measurements for hemorrhages or any cerebral edema or measurement of intracranial structures. We have proof of concept data from IRB-approved studies at 2 centers, which was Wake Forest and UT Austin. We were recently awarded a major grant from the American Heart Association and did a very successful FDA pre-sub just this month. We're on track for our first 510K at the end of 2026. So the dream is to be in every ambulance assisting with pre-hospital triage for strokes. But we start off with a very small baby step, going towards existing exams at stroke centers, which are already done on recovering stroke patients. The limitation being they don't have enough sonographers that are trained to do these exams, so a lot of centers that should be doing them are unable to, and even the ones that are able to are only able to do them on select patients. There is a clear regulatory pathway through which was validated through the Q-Sub. We would be going for a Class 2 510K with no clinical trials needed. Alongside the clinical value propositions, we also bring in very strong financial incentives for the hospitals through direct CPT reimbursement for the scans that we're going for, alongside excellent savings on the DRG through efficiency, through reduced length of stay, and finally, by improving quality of care, we improve the hospital's bonus on Medicare value-based plans. The team has extensive experience bringing medical devices like surgical robots and medical imaging systems to market. We also have a very strong strategic and clinical advisory board and have a joint partnership with one of the leading ultrasound manufacturers in the world, both for development and manufacturing. We're actively seeking partnerships as we move forward, help us make disabilities from strokes a thing of the past. Thank you.
Okay, so then I can help facilitate the questions. Who has a question? Anyone? Mike?
No, I said hello.
Oh, Maurice?
Can you talk about the training that is required for safe operation?
Sure.
So again, this is what kind of staff, what kind of training, and how long would that take to implement?
Nicole, how do I go back to my slide? Well, the system is robotic and fully autonomous. It doesn't require a skilled person, just a trained person to put it on. Everything else is fully autonomous. The acquisition is completely autonomous, and the scans, we deliver cross-sectional views just like a CT. So they're sent away to a remote radiologist, or in case of a hospital, they're just sent to the PAC server, and the rest of the workflow is exactly like how it would be for a CT or MRI. Yeah.
Anything else? Yes.
Yeah, I was going to ask, similar to his question, I heard you say a couple of different, actually a lot of things. It's a great presentation, but is this primarily intended for the pre-hospital setting? Or
That's
is
the dream.
Okay.
But it's applicable to every setting. So the entire continuum of care, which is EMS, EDs, ICU, and also post-stroke monitoring for long-term post-acute care. We start off in ICUs with cerebrovascular flow monitoring, which is called a transcranial Doppler exam right now. Again, very difficult to do, and it's very limited in terms of what they can do right with the existing technology. We just scale that up with the volumetric reconstructions, ease of use, and full autonomy.
Great, thank you very much.
Thank you.
Thank you.